All right, I'm going to go to full screen here.
Okay. John, would you mind typing in the website, please, in the chat, and then also the Connect email, because I'm going to talk about those in a second.
It's all second nature to me now. So, but yes, I will.
Thank you.
And
All
Alicia,
right.
keep monitoring the chat for questions because I can't see it. in the
Yep,
screen.
John and I will be doing that.
We'll do Q&A at the end.
Yes. So the attendees who are coming on, we're just gonna wait maybe like 30 more seconds. It looks like some people are still joining, and then we'll get started.
Absolutely.
All right. Well, some people typically join a little bit after, so we'll get started for the sake of time. My computer does say 7:02. So on behalf of the Epilepsy Foundation of Wisconsin, we want to welcome you all to this week's virtual meetup. Thank you so much for being here. For those that don't know who I am, my name is Alicia Thompson. I'm the program manager here at the foundation. I've been almost going on 2 years now, so it's been really fun. We also have John Mirasola on the call with us. John, just want to say wave and say hello.
Hello, everybody. I work with Alicia at the foundation. I work mostly with support and
Yep, client services. Yep, thanks, John.
services. Yeah.
No problem. And then we also with us tonight have Professor and Pharmacist Barry Goodall from the UW School of Pharmacy, and you'll get to hear from him in just a second. So tonight's topic, as you can probably see on your screen, we're talking bone health and epilepsy. But before we get into that, as always, if you've been on these before, I have a few housekeeping things. So just bear with me for a second. First of all, we are recording this. You can find it on our website by early next week. And John did type that, or he's typing that right now in the chat. It is epilepsy. Yep, there we go. epilepsywisconsin.org. We have a video library that you can check it out at. And then also you are muted and your microphones are off, just so you know, but we of course encourage questions. Barry loves questions, so please ask away. We're gonna do Q&A at the end. And there is a button at the bottom of your screen that you can use to submit your questions. John and I will be monitoring those. For sake of time, we may not get to answer all of them this evening. So if that is the case, or if you think of something after the fact, you can use our connect@epilepsywisconsin.org email, and John will also put that in the chat so you can find that if you have any further questions. I believe that is all the housekeeping stuff. So Barry, I'm gonna turn it over to you if you want to say hi and get started.
Great, thanks, Alicia. So good evening, everybody. Thanks for tuning in this evening. So again, my name's Barry Goodall. I am a professor of pharmacy at UW School of Pharmacy. My area of research is in anti-seizure medication, adult epilepsy really, but anti-seizure medication, drugs. I kind of focus on drug interactions and adverse effects, side effects of anti-seizure medications. And my clinical practice is at the Madison VA in the Comprehensive Epilepsy Program. So yes, as Alicia said, and you can see from the title, I really want to talk about this whole idea of bone health and epilepsy. And you know, I'm really very hopeful that a lot of you that are out there have already know something about this, because we've been talking about it for a while, but I'll try to sort of update you to kind of where things are at, and be glad to answer any questions. But if nothing else, I want to empower those of you that are patients or caregivers of patients that this is a topic that at some point you should bring up with your physician or your healthcare provider. Okay, so let's get started here. First, I'm going to show you a lot of photographs here, but let's talk about what normal bone is. Now, it used to be, a couple dozen years ago, people thought that, we knew bones do a lot of things. They make blood cells, red blood cells, they make platelets, they make a lot of stuff. But we used to think bone was kind of let's call it a static thing. You know, it was like the scaffolding of a house, right? It was the studs. We now know that that's really not true, and that bone is very dynamic. And what do I mean by that? It is constantly being torn down and rebuilt, remodeled. We call it remodeling, constantly. And so this is an ongoing process. And I'll show you a graph here in a second, but you know, it really starts almost from the moment we're born, this whole dynamic process, and it really continues throughout most of our life. But you'll see in a second that really the biggest building process, if I'm building my skeleton, I'm building my house, is really in my teenage years up until in my mid-20s or so. And that's an important point. Keep that in mind, because I'm going to bring that back when we talk about risks. Just a couple terms out here. There's a couple cells that we know that are very important. We have something you'll read about or hear about called osteoblasts. These are the cells that make bone, if you will. But we also, again, we're building and remodeling, we're building and tearing down. We have something called cells osteoclasts. So basically, they sort of tear things down and rebuild it up again. And keep that in mind, because when we talk about some of the things about with calcium and vitamin D, it's kind of important to remember these two cells. All right, a little bit more about what our bone is actually looks like. As I'm sure, you know, again, like I think most people probably recognize that most of bone is calcium. And, you know, we have two different types of bone. I won't go into a whole lot of detail about that, but we have something called, you can see from the cartoon here, at least the one in the lower cartoon, we have a picture of cortical bone and trabecular bone. And it's really, when you hear about cortical bone is really what gives that rigidity to bones, why they don't tend to bend very well. It's what gives our skeleton strength. And the more we use that, the more pressure and the weight bearing and all that stuff that we do on our bones, we actually can strengthen that cortical bone. The trabecular bone is kind of the inside of our bones, and that's sort of the spongy area of bone, and that's where a lot of other stuff goes on. A lot of that is frankly made up of water and a lot of collagen and other things. But as I sort of mentioned, that, you know, this is a very dynamic organism. It's constantly building and tearing down and building and tearing down. Now, what do we know that controls this whole building and tearing down thing? And there's a few things that are really kind of important to us. One we're going to spend a lot of time talking about is vitamin D and the importance of vitamin D and how that may actually play into being important with epilepsy. There's some hormones like parathyroid hormone, estrogen, both estrogen and testosterone, but really estrogen is also very important in both building of bone and maintaining of that bone. So again, that may be very important in a woman's lifespan as you think about as go through, you know, puberty and into eventually into menopause, how changes in those hormone levels might affect our bones. But keep that vitamin D thing in mind. Okay, so let's talk about a little bit more about this timeline of bone health. I think I mentioned this a couple moments ago. Really, it's when we're kids and we're teenagers that we're building our bones. Now, this slide says women reach peak bone mass by 25. But really, I want to include men here. And if I can leave you with a few pearls tonight, people often think of osteoporosis as being a female disease state. True, the preponderance of patients with osteoporosis are women, again, because of these hormonal changes that take place over time. But men get osteoporosis too. And in fact, if we look at patient populations with epilepsy, and whether it's in North America or Europe or whatever, where these studies have been done, it's about a 50-50 proposition that both men and women with epilepsy, and specifically receiving certain types of anti-seizure medications, can also develop osteoporosis. So it's an equal opportunity disease. Once we start, after we hit those wonderful young years, we get into our mid-20s, we're starting to lose bone. And that process can accelerate over time. And that's going to happen in all of us, in every one of us. That process, once we hit after our mid-20s, early 30s, we're really starting to lose bone. But it's that, what other things, those things that I said regulate bones, can that speed the process up? And that's where we need to be really mindful. All right, so this really kind of, this cartoon really, I think sort of illustrates what I was talking about here. If you look at the vertical axis, that's our bone mass. The bigger the number, the stronger that bone is, and versus over the span of life. And again, you can see that, you know, the differences, the peak bone years come about the same time in both men and women. But again, the important point here, all of us, once we get past our youth here and we start really getting into 30s and 40s, is when this bone loss begins to occur. So all of us, if we're fortunate enough, will maintain healthy bone throughout the course of our lifetimes, that we don't really need to worry about fractures. But what happens if we begin to lose too much? And that's really, and I'll show you at the very end kind of what some of the diagnostics are, but what happens if we develop osteoporosis? By the way, there's two terms I'm going to be using. One is called osteopenia, which really just means we're thinning of the bone. It's getting a little bit more fragile, and it's on the road to osteoporosis. But osteoporosis is a specific classification of when our bone really becomes fragile and thin. And the real danger for that, it puts us at risk for fractures. Now, I have on this slide some of those risk factors. There's some things we can do some things about, other things we can't. Our ethnicity, not much we can do about that. We do see, though, that in people of European or Asian extraction, it's a risk factor for that. Advanced age, we can't do much about that. We can argue that's a good thing. Women, again, probably because of the changes in estrogen over time. And again, all the things that follow below that, premature menopause and actually post-menopause. Again, think estrogen here can accelerate those. Now, there's things we can't do anything about. There are some things we can. And here are the risk factors. And again, this would be another slide I would hope that you would think about. Excess alcohol use. Now, arguably, most of this work has been done in people who probably qualify as alcoholic, but even people who regularly consume alcohol and are certainly not alcohol abusers, but regularly consume alcohol, seem to be at increased risk. So the first bit of advice I would give, if you have been given a diagnosis of osteopenia, for example, or osteoporosis, and you do drink, think about modifying the alcohol intake. Cigarette use, tobacco use, long been established as a risk factor. I think all of us, you know, every patient I encourage, please not smoke, but clearly if you've had a diagnosis of osteopenia or osteoporosis, not to do it. We're going to talk a little bit more about calcium and vitamin D in a minute, so let's hold on that one. Inadequate physical activity. I mentioned earlier that one of the things our bone does, this dynamic organ, that if we use our bones, especially say our legs, we walk, we do weight-bearing kinds of exercises over the course of our lifetime, that tends to stimulate bone production, those osteoblasts. So I encourage all patients, if they are capable of doing it, if they don't have the physical limitations, to try to walk. We don't need to be running. You don't need to do, you know, heavy aerobics, but just weight-bearing things. Just simply walking and getting into a good habit of walking can be great for some of those long bones. You know, we talk about inadequate sunlight exposure a lot. And I will tell you some of the research that I've been involved with, both here in North America, looking at patients with epilepsy that have lived in some very sunny climates like Miami, as well as work I collaborated on with a pediatric epilepsy group in Cape Town, South Africa, a couple years ago. And you know what? We found that even in South Africa in the summer, and we found even in Miami, that at least our patients with epilepsy, sunlight didn't really matter that much, solar exposure. Not that I'm arguing against being out in the sun. That may be different for people who don't have other risk factors, but it's probably not quite as important to a population of patients with epilepsy as we used to think. Part of that may very well be because trying to prevent skin cancer using sunscreens may be filtering out some of the beneficial effects of sunlight in forming vitamin D. And then again, we've talked about things like estrogen deficiency. Now, what about medicines? That's really kind of what we're here to talk about tonight. There's a few drugs that we've learned over the years, in addition to alcohol, that can lead one and increase the risk of osteoporosis and eventually fractures due to that. Corticosteroids that people may be taking. So again, think about medicines maybe using for things such as asthma or other chronic inflammatory conditions. But the class of drugs I really want to focus on, though, that's germane to our conversation tonight, are the anti-seizure medications. By the way, folks, just to let you know, we're trying as an epilepsy community to get away from the term anti-epileptic drugs to go to anti-seizure medications. I still tend to use both of them interchangeably. All right, so I talked about what osteoporosis is. And basically, it's compromised or weakened and decreased bone strength. And what that ultimately means is bone frailty and fragility. So if you look at, again, my photographs here, my x-rays, I've got on the left side what a normal bone would look like, and on the right side what someone with osteoporosis would have. So let's, I hear this sometimes a lot. It's kind of surprising, that people don't tend to think, they've heard of osteoporosis, but really the thing that's the most concerning about the osteoporosis is the fractures. Say like a hip fracture, a fracture of long bones, a fracture in one of your vertebrae, in a forearm, those kind of things. Well, people have heard of osteoporosis, but they don't, when I ask the question, do you know how common you get bad breaks from these kind of fractures? And people think, well, it's not that common. Well, if you look at this, this graphic that I have here on the left, and I know it's kind of a lot of colors here, but if you look at the different types of fractures versus, the incidence of other things that we know are pretty common, like strokes and heart attack, when I add up all those different types of fractures, it's pretty staggering. And I will tell you, the fractures that are going to end patients up in hospital are the blue one there, the darker blue, hip fractures, vertebral fractures, vertebrae fractures in one's back that may not necessarily land you in the hospital, but it's a big cause of chronic back pain. And pelvic fractures, the purple line here, that is, again, something else that's going to land you in a hospital and potentially a nursing home. So again, fractures are very, very common. Just want to emphasize the point, we frequently talk about osteoporosis in women, but again, this is an equal opportunity player, and especially the osteoporotic, those fractures that can occur happen equally in men. All right, let me talk more specifically about epilepsy, patients with epilepsy. So when I first started getting interested in this from a research point of view, it was probably about 25 years ago. And at that point in time, we really thought that the only patients with epilepsy that were vulnerable were patients in an institutionalized setting, meaning centers for developmentally disabled. And we really thought that it was really because a lot of these patients were wheelchair bound and immobile. And really the belief was that really other patients with epilepsy were really not probably at any greater risk than anybody else out there. And what we learned, and there's some great work by a team of epilepsy folks at Columbia University that I think really led the nation, if not the world, in this research. And what they really proved and they found out was that, well, that's just not true. That's one of those myths. But I think it's still, a lot of healthcare providers still believe that. They don't necessarily understand that patients with epilepsy are in fact at greater risk. And in fact, when we talk about these fractures, they may be up 4, 5, 6 times greater risk than the average patient or the regular patient population. Where are they getting these fractures? Well, again, in the vertebrae, they're getting at the femoral neck. So think hip fractures, the clavicle and ankle, and that's where these fractures are occurring. Now, the important thing, you'll also hear the term a lot. We talk about pathologic fractures versus non-pathologic fracture. And really what we're talking about, the difference here is if I'm climbing on the roof of my house to clear ice out of my gutters and I fall off a ladder, by the way, I have no intention of doing that, and I fall and I break a leg, well, that's would be expected, this high velocity fracture. But the fractures that really make us worried are when patients tell us they tripped on the carpet in their room and they were standing. They weren't running, they were standing and they fell over and they broke something. Or I just recently had a patient who had a bad respiratory tract infection. It was not COVID, but was coughing so hard, they were complaining of bad persistent backaches. And we ordered a chest x-ray and lo and behold, they had multiple fractures in their rib cage. So again, that led us to, looking down the road to doing more definitive testing that I'll talk about. So if you know people that have had fractures that have been sort of these low impact kind of fractures, and maybe they weren't terribly bad, maybe they got kind of written off or dismissed, and especially if they have epilepsy, and especially if they're a little bit older, they really should go back to their healthcare provider and say, maybe we need to do some more definitive testing. So one of the other myths that's out there is that, well, fractures, we recognize that sometimes patients who have seizures, especially convulsions, that, they fall to the ground, that those are where the fractures would come from. And yes, most certainly that puts patients at increased risk for fracture. But again, not always. In fact, probably at least half of all the fractures we see have nothing at all to do with a patient having a seizure. All right, so this is a little bit of a complicated slide. I apologize for that. So let me just try to give you, I'll try to skim through this and tell you what we think. So again, I need to get back to vitamin D. So what does vitamin D do? What vitamin D does, it facilitates us absorbing calcium from, it does a lot of different things, but in terms of bones, one of the important things is it facilitates us absorbing calcium out of our diet, out of our gut, and to get it in so our bones can take it up. Now, we need to maintain, as human beings, we have a fairly tight range in which we need to maintain calcium levels in our blood, because calcium is important for all sorts of different activity. If we're not able to absorb enough calcium from our diet, so say I've got really low vitamin D levels, if I'm not able to absorb calcium, I need to take it from somewhere to continue living. So if I'm not absorbing it, where do I take it from? Think back to those pictures I showed you of all that bone. I rob it from my bones. So our bones are our biggest sort of savings account or repository, if you will, for calcium. So if I'm not getting enough calcium in through my diet or vitamin D or a combination of both those things, I'm going to take it away. And that's one of the leading theories that we have, amongst a few other things, of what's going on with osteoporosis, specifically in epilepsy, as an added risk. And why is that? Well, vitamin D, if you can see through my cartoon here, and again, I know it's a little bit complicated, but one of our biggest ways, that we form vitamin D is, again, sunlight, but we also get some vitamin D through our diet. And vitamin D has to sort of be turned into something that is useful to us to absorb that calcium. But we also have to turn it into something. Our kidneys play a role, but so does our liver. And one of the theories that we have is that very simply, this is a drug interaction. That if I am taking medicines that are called enzyme inducers, okay, and you may have heard this term before, but if I'm taking anti-seizure medications that are revving up my liver to chew other drugs up, well, vitamin D is really just a drug. And one of our theories is that some of our older anti-seizure medicines, so think Tegretol, Dilantin, phenobarbital, maybe some of our newer drugs, maybe things like Trileptal, maybe we don't have as much good data, but think about the older guys, Dilantin, phenobarbital, Tegretol, that I'm revving my liver up, and what I'm doing is I'm chewing my vitamin D up more, and I'm lowering my blood levels. So it's really, in some respects, that's the reason I got interested in this, it's really a drug interaction. I'm happy to answer questions as we go. Here's for you is a little bit more of a list of those anti-seizure medications. And again, the guys that we're worrying about are those ones I have under the category of enzyme inducing. Now, I also have a category here of non-enzyme inducing. And what that means is, to the best of our knowledge, these medicines do not appear to affect vitamin D levels. Now, kind of the drug that's sort of in the weird in-between place here is valproic acid, or Depakote. Depakote doesn't necessarily, well, some reports says it may speed up vitamin D breakdown in the body. It may be doing other things. There have been reports over the years, primarily from some folks, investigators in Italy, that have suggested that in fact, valproic acid, especially in kids, may be altering bone formation. That may also be due to testosterone changes and estrogen changes. It's really unclear. But valproic acid may also be a risk factor. We just simply still don't know enough. Okay, so I've talked a little bit about patients with epilepsy and fractures. I won't go through and read you a lot of studies. But in EIAED, by the way, means enzyme inducing anti-epileptic drug. What we basically found, but very simply, is that patients who are currently taking those enzyme inducing drugs or anti-seizure medications, those people may be at increased risk for both osteoporosis, low vitamin D, osteoporosis, and fracture. Now, what I will say that the problem with all of this literature is, if you think back to those that graph that I showed you earlier in the presentation, showing where I showed that peak bone mass when we form it and when it breaks down, is what a lot of the studies do not tell us is, well, what if a young woman or man was on carbamazepine, Tegretol, or phenytoin, Dilantin, for a lot of years up until their teenage years. Say they're 50 years old now. Maybe they took those drugs when they were in their teens to mid-20s. They've long since been discontinued and put on another medicine. Sometimes the flaw in that, people may say, you're not really at risk because you're not receiving one of those inducers, one of those medicines that may cause a drug interaction. So my next pearl, my advice for you guys, is that when you're having this conversation with your healthcare provider, even if you're on a drug that's not been associated right now with alterations in your bone health, but you were taking it years ago, maybe a completely different physician that was taking care of you, that's important for you to bring up and remind them. Say, I was taking these other drugs that I heard about could cause some bone issues back for about 15 years or so ago, a long time ago. Is it worth us looking a little bit further and a little bit deeper? So, one of the things a lot of people ask is, well, what are the guidelines? And a lot of physicians will say, well, what is the current guideline for doing this? And the problem is, unfortunately, our societies still haven't generated specific guidelines for how to manage it. So in some respects, it's going to be up to the individual physician. But again, there's a lot of literature out there, and I think a lot of epilepsy doctors and epilepsy centers are pretty attuned to this. Okay, so what kind of things can you be doing? What kind of things can you do? And a lot of healthcare plans will pay for this, especially if you're over a certain age. But again, if you can, physicians can usually get an authorization to get this for people with epilepsy. It's something you may have heard called a DEXA, which stands for dual energy X-ray absorptiometry. And really what this is a fancy X-ray. It's takes a picture of your bones, and we look at a variety of places in your bones. We look at your forearms, we look at your hips and long bones and legs, and we really just measure it, and we can plot this and we can tell. So it's painless, it's quick, it's easy to do, and it's very, very, very reliable. So I encourage all of our patients, and I'm putting this up here just in case you've ever seen the reports before. I actively encourage all of my patients that really about every couple years, depending on what medicines they were on or what medicines they currently are on, every couple years to think about getting one of these DEXA scans. Again, this is not a test you would want to be doing, say, on every 3 months, because it takes a long time for our bones to show a difference here. There's another thing that your healthcare provider may or may not do, is you may hear about it. It's called the FRAX, this was something developed by the World Health Organization. And it's basically, again, it's a survey and it's a questionnaire. It's a thing that your doctor can put in. They can put in kind of what risk factors, how old you are, and a variety of things you see on here, and we can calculate a score. And this is very quick and easy to do. I encourage all of our providers to do a FRAX because it gives us an estimate of risk of like 10 years down the road, what your potential for a fracture is. And again, we need to have that DEXA done ahead of time. Okay, we'll sort of wrap up here so I can address some questions. So I'm getting back to my vitamin D and calcium story. I already told you about the drug interaction. So I encourage all of my patients, and we do this routinely in all of our patients, is to get a vitamin D level. There is a specific part of the vitamin D, or there's a lot of vitamin D molecules that are, metabolites, but your doctor will know this, of ordering a vitamin D level. I, again, think this should be about every year. This should be part of, every year, every other year at most, to get this level. And the number we're aiming for, what all of our specialists out there in bones tell us, is a level above 30. So again, if you've not had a vitamin D, or your loved one has not had a vitamin D level done, probably it's a reasonable thing to get, if nothing else, to benchmark. The standard recommendations, the RDAs out there, for how much vitamin D and calcium you need to take, you can see the numbers that are up here. Here's what I will tell you, and we've done some research and published in this area, that the typical vitamin D dose, if your vitamin D level is really low, and especially if you're on one of these medicines that, causing the drug interaction that rev it up, the metabolism, you're going to need more than this. So again, taking an over-the-counter, I encourage everybody, especially those of us of a certain age, to take vitamin D and a calcium every day. It's just good for us in a lot of different ways. But I will tell you, the over-the-counter supplements, if your vitamin D level is low, is not going to make it. You're going to need to have your doctor write an order for a higher potency vitamin D. And the good news is that's very inexpensive, and it's easy to take. And I won't belabor you with the doses that we give. Just know that the over-the-counter things are probably not sufficient. A lot of other things, I think we'll finish up here. There's a lot of other things we can do. Again, if you're the biggest risk that I see in my patients, if they're having dizziness and their balance and their gait is off with their seizure medicines, please bring that up to your doctor, because I want to do things that modify your risk of falling. There's other medicines, sedative types medicines that people sometimes are taking. Again, some patients, if they get, especially they get really, really dizzy and dizzy woozy from them, and they have osteoporosis, puts them at risk for falls. So have those conversations with your healthcare provider, have those conversations with your pharmacist. Again, in some places, you can get sort of a home safety evaluation. Sometimes insurance will or will not pay for that, and these physical and occupational therapists can come out and make recommendations. But these are all things that we can do to promote safety. And finally, there are prescription medicines. I'm not going to get into that tonight, but just know that there are trials, and there is some beginning to be encouraging data that some of these specific osteoporosis medicines, for years we simply did not know about our patients with epilepsy, that we found that some of these drugs that they can make a little bit of a difference, but again, it's a marginal difference. The best thing that I want to do for my patients is to try to catch this process early and try to get the vitamin D, maybe modify seizure medicines, and do all those things to prevent these fractures from happening. So with that, I am going to stop talking there, and I am happy at this point to open this up for questions.
Thank you very much, Barry. We do have some questions. So I am just going to, hang on one second, open this up.
So while you're looking up questions, Alicia,
yeah.
as a side commentary, remember I told you my dog never comes down here?
Yes.
He's been very busy during this whole presentation, pulling papers off my bookshelf and tearing them up. Are you proud that I kept my focus on for the entire talk?
I thought something was going on, but you did a good job. It's okay. All right, so we have a question here. So I have broken my clavicle when I was in my teens or so. I have also dislocated my patella on my left knee. One side of my knee muscle was stronger than the other. Do those have any relation with seizures or osteoporosis?
So probably not osteoporosis. I think, people, a lot of people will end up breaking their clavicle, if they're, when they're teenagers, especially if they're playing sports and doing that. Clavicle's pretty fragile bone. Doesn't take a lot to break it. And the dislocation probably, from what you're describing, that's more of a tendency, probably not. However, it's, again, it depended if there was, for the fracture, if this occurred, from something trivial, someone patting you on the shoulders or whatever, that happened, then probably should be looked at closer, but probably not.
Okay, thanks, Barry. Let's see, whoops. Oh gosh, sorry, I'm having computer problems. Okay. If people with epilepsy break a bone, does it take longer to heal than someone without epilepsy?
So, no, not just simply not having epilepsy. However, if one has osteoporosis, so again, think back to that image that I showed you of that sort of thinning bone, that very fragile bone. Yeah, sometimes that can take longer, to fix. It can be harder to fix, say if it's a hip fracture, than potentially, doing a hip replacement or something in an otherwise healthy person. But having epilepsy in and of itself, no. Please, I want people to understand that having epilepsy in itself without changes in vitamin D and bone mineral density, you break a bone skiing or whatever, it's going to heal like everybody else.
Great, thank you. Let's see. So you touched on this a little bit, Barry, but I'll ask this. So someone submitted, which anti-seizure medications affect the bones?
So the ones that we know for sure, if you go back, let me see if I'll go back up here.
Yeah, we can still see your slide. So if you want to pull something up, that's.
Yeah, that's what I'm going to go do here. I'm going to go to this guy right here. So the ones that we have probably the best evidence for are really probably the top three in the left corner under enzyme inducing. So the phenobarbital, phenytoin, which is dilantin amongst others, and carbamazepine. The other drugs we don't have as much data, long-term data on, And for some of our newer drugs like cenobamate, we just simply have none. And again, I mentioned on the other column, valproic acid is kind of a strange one. It's probably doing some different things, but it may be associated with it. And probably more of that has been found in kids, to be honest. But again, the thing that I want to leave folks with is, again, maybe where I'm concerned, it takes a good medication history. People may have been on these other drugs, so when I'm making my bones, when I'm, if I'm a teenager and I'm on one of these medicines, and if I've altered how I'm making bone then, I'm really probably not going to catch up maybe by the time I'm 40 and I switch over to, say, lamotrigine, which we think is relatively safe, for example, or Keppra, levetiracetam. People forget, sometimes clinicians will forget that part. Especially if it's a brand new patient, they say, you're not on a drug associated with osteoporosis. Yeah, but I was. So this is where patients be empowered to at least ask the question and let their provider, interpret that.
Yeah, great. So I'm assuming this one is asking, so it says, does more anti-seizure medication make our risks worse? So I'm gathering that as if they're on multiple anti-seizure meds, does that increase the risk at all or make it worse?
That's a really interesting question, and it's a little bit unclear from the studies that have been done if like whether the dose that you're getting and the blood levels make a whole lot of difference. The way the gold standard, and here's what I would suggest, and this is something that's so dead easy, everybody can do this, is the next, if you've never had a vitamin D level check, is ask your provider when you go in, say, hey, could we add, I know you're going to measure a bunch of laboratories and measure some blood levels and a lot of other things, can we get a vitamin D level? Because I've never had one checked. And again, what we do, and if it's below that number, at least we and a lot in our community accept is around 30, then that's when we start thinking about maybe let's look a little bit deeper. If it's above 30, you probably still should get a DEXA, especially women or any man, over 50 who's on an anti-seizure medicine probably ought to get a DEXA about every couple of years. And that's what we do in our practice. But again, the cheap and easy thing to do is get a vitamin D level.
Yeah, that's great. I'm glad that you mentioned that also. I don't think there's probably a lot of people that don't really know that they can ask that. Yeah. So another question, if we're at a bigger risk for bone damage while we have epilepsy and are taking meds, what type of exercise and how much is safe?
So I'm gonna, that's a great question. Walking is still one of the best exercises. And if it's miserable, when it's safe for everybody to be back out and walking like in a mall, I don't want people out exposing themselves to a greater infectious risk right now. But walking is great. In terms of doing other kinds of exercise, because again, there's a whole range of people out there. That is a conversation I think people need to have with their doctor or their healthcare provider. What is safe for you to be doing? But again, things like walking are just tremendous.
Great, wonderful. Let me see. Are there foods besides milk good for calcium, or is a vitamin D pill the best alternative to milk? That's actually a great question because I don't drink a ton of milk.
Yeah, I only drink milk and lattes. So, yogurt is a good source. Cottage cheese is a good source. And boy, I should have included something because I'm now all of a sudden I'm drawing a blank of things that are good sources of calcium and vitamin D. The grains, tend to be enriched with vitamin D. There are certain fish that are really good for sources of vitamin D. Boy, I apologize to you guys. I don't have a lot of the list of the foods off the top of my head. But there's good guides that are out there to that. And I always think, quite frankly, calories aside, I think that a lot of these nutrients are best derived from our diet. That's the way we were designed. to be getting those. But if you can't, and if there's caloric or dietary restrictions, you know, a vitamin D supplement with calcium is pretty easy to tolerate.
Great, thank you. Barry, is there any red flags, I guess is the way I'll word it, that people can kind of look for if osteoporosis is kind of, or their bone health is being impacted in some way? I just didn't know if there's any signs or symptoms that people can look for.
Yeah, so, well, you know, again, if you've had, you know, these sort of unexplained fractures, now typically that's going to mean you're going to end up, you know, seeing a doctor somewhere, you know, for a big fracture.
Yeah.
This is, you know, in many people, it's somewhat of a silent, you know, disorder. I mean, you know, we can be well down the road to having developing osteoporosis and be well down the road to having a major fracture and not know it. So again, the earlier stage of this, if you will, is something called osteopenia.
Mm-hmm.
And there's a lot of fairly active, not terribly old adults that are running around out there with osteopenia that you don't know until you look. So sadly, no.
Okay.
I will tell you that and again, I don't want everybody with a backache, please do not overstate it, with a backache going and asking for an x-ray. That's not what I'm saying. But I've had patients who have had like very persistent backaches, especially after they've had a big seizure. I mean, by persistent, I mean it lasts, you know, for weeks,
Mm-hmm.
not just in 24, 48 hours. And, you know, we go and look and they've had vertebral fractures.
Mm-hmm.
So again, unfortunately, this is sort of a silent disorder.
Okay, thank you very much. I don't see any other, hold on. Can low vitamin D affect bones between the teeth?
So you mean like in the jaw, I presume that's what meaning.
Yep. Yes.
That's a interesting question. So can jaw strength and fragility be affected by low vitamin Ds? And I do not know the answer to that.
Okay.
Great question.
That is a great question. Thank you. That is the last question that I see, Barry, but I do want to just welcome everybody again. John did type in the Connect email. So if you think of something after the fact, please feel free to send your question to that email, and then we will get it. I will get it to Barry, and then I will get the answer back to you. We can definitely do that. Yeah.
So folks, just let me leave you with one thing tonight. So again, we've talked about a lot of information tonight. It's a lot to take in.
Mm-hmm.
And obviously this is a pretty big, broad topic. So the one thing I just, you know, my whole goal for this is that if you've never had the conversation with your doctor about this, it's, you know, at the next visit when you're writing in your notes, and everybody should have a note before they go into the doctor's office, you know, what I'm going to ask, what I need to talk about. Ask about, gee, because of the medicines I'm on, because of, you know, blah, 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 should we be doing any of these tests like a vitamin D level, or maybe getting a DEXA scan, worried about osteoporosis? You know, bring up the conversation. And in the American Academy of Neurology now, it's actually for epilepsy, is part of our quality measures to talk about bone health. So it's something that should be on most people's minds, but you know, sometimes the visit gets busy. So right. Just talk to quote Greg Grunberg, who many of you may know, you know, from the Talk About It, you know, series, just talk about it.
Yes. Wonderful. Well, Barry, I think we'll end on that. That was perfect way to end it. Thank you so much for your time and your knowledge. We really appreciate you being here this evening.
Thanks, folks.
And you go let your dog out and have a good night.
No, now I got to clean up the mess. So was it that obvious that could you hear noise, or you could just see me trying to turn my head?
No, it was just some rustling. It wasn't anything too bad. It's okay.
She never does that, except she knew I was busy.
Of course. Yeah.
All right.
All right, everybody. Have a wonderful night. Thank you.
Bye-bye.
Bye-bye.